Purva, shall I start? Purva? Okay, good evening to all of you. This time I'll start with a short case. Sorry. Hold on, just 1 minute. Can you see my slides?
Yes, sir.
Yeah, right. I'll start with a short case first. This patient I saw 2 days back. This is a story of a 40-year-old female. She is an old case of rheumatoid arthritis. This lady sustained a fracture during a fall from the bike 3 months back and was put on a plaster. 3 days later, patient noticed numbness of the tip of the right thumb, which had been persisting since then. I saw the X-ray, they put some rod or something in the humerus. Since the numbness was persisting, she came to me to rule out any neurological problem. So only complaint is numbness of the tip of the thumb. Now she will point out where the numbness is. That is the area she's complaining numbness. No other complaints as far as she's concerned. So I started examining her. I noticed that all thenar muscles are wasted. His abductor pollicis brevis is weak, normal on the left side. Flexor pollicis longus normal bilaterally. Then flexor pollicis brevis also normal, but opponent see is on the right side is grossly weak. You cannot oppose the thumb and little finger. Introshevae normal. Examine sensation. Only except only at the tip of the there it's decreased. All other area normal. This finger normal. So that's a finding in this patient. So motor severe wasting of the thenar muscles. Weakness of right abductor pollicis brevis, opponent's pollicis. Flexor pollicis is normal. All other small muscles normal. DTR all normal. Sensation mild impairment in the tip of the thumb. Other fingers are all normal. So what is your diagnosis of this patient?
Sir, was the numbness more on the dorsal aspect or on the palmar aspect?
Palmar aspect. She is telling on the pulp of the thumb.
The proximal every other muscles are normal.
The only muscle affected is the thenar muscle, that too abductor pollicis brevis and opponent's pollicis brevis.
So it's not following a nerve pattern, sir. It's a patchy involvement, sir.
Okay.
So patchy involvement of the palmar cutaneous branch of the median nerve, which goes above the carpal tunnel, sir. So may cause numbness or the radial nerve.
No. The numbness is the tip of the big toe. I'll show the area. This is the area she's pointing. That is the area that's the area. Okay. That is only the tip of the thumb.
Then the radial cutaneous nerve may be involved.
But it is in the palmar aspect.
So which all muscles are affected? Flexor pollicis brevis and abductor pollicis brevis.
Abductor pollicis brevis. And sorry, not flexor, opponents and abductor pollicis. Flexor relatively normal. Flexor pollicis brevis.
Partial CTS.
CTS. Yeah, the common things are common. The most common thing is CTS, no?
CTS.
Yeah. But she in fact all followed a fracture of the right arm. That's another glitch in that patient. Okay, but still the pattern fits in with the carpal tunnel syndrome. Okay, any objection to anyone?
No,
What
sir.
about sensory on the dorsal aspect of the
No sensory,
distal
no
phalanx?
sensory, no sensory on the dorsal aspect of the thumb or any other area.
But atypical for a usual carpal tunnel syndrome.
Yeah, right. That's a common thing you have to keep in mind. Okay. Now let us see these are the findings. So what test you need?
Sir, in 3 months, can we expect a severe wasting, sir?
That we do not know how long it has been there. It should severe wasting.
Sir, is it common to have objective sensory loss with the carpal tunnel syndrome, sir?
Yeah, they can definitely have.
Okay, sir.
In severe carpal tunnel, they can even the fingers can develop trophic ulcers also in carpal tunnel syndrome.
Okay.
I have seen that. Yeah. So what test you? Pardon?
Phalanx maneuver and tunnel test positivity. The reverse.
Yeah, right. That did not do because I just anyway that should be done. But numbness is persisting on the tip of the tongue only, and tip of the finger. Anyway, that should have been done. So what test you like to? We have to confirm whatever it is now.
NCS, sir.
NCS. So this NCS. So no potentials are picked up from the thenar muscle, abductor pollicis brevis. Left median normal. Sensory potentials normal. Right is 60. And FA latency is normal. Now what will you do?
Can you
So
tell once
some
again, sir?
kind.
Pardon?
Can you tell once again? Just show that once again.
Yeah, sure. This is the motor conduction, no potentials picked up from the thenar muscle. Abductor pollicis brevis. Other muscles normal. Sensory potential is normal.
It's a
It's a
typical
partial entrapment of the median nerve due to compressive neuropathy or any compartment syndrome or myositis ossificans post the plastering of the arm after the injury. So may lead to this axonal pattern of median nerve.
But no other muscle is affected, such as severe wasting in the thenar, but no other muscle supply with the median is affected. If you want to put lesion in the
evaluation of brachial plexus to be evaluated.
Okay. When you get isolate wasting in the thumb with the normal median sensory rule out,
Neurogenic thoracic outlets.
Neurogenic severe.
Thoracic outlets.
right?
C5.
Okay, right. C5. Okay.
But
So
that won't cause sensory impairment on the thumb, no?
that cannot cause sensory impairment in
No.
the thumb. That called sensory impairment should be in the little finger. Here the
Sir,
tip of the
put that one, please. Like
In
this.
sometimes CTS, all the sensories in symptom may be there. It may not be picked up on the.
Yeah, correct. But the point is that he has got almost zero power, no motor potential. But till no snap affected is little odd for a carpal tunnel syndrome. Is it so?
It's a proximal conduction block.
Yeah, but still, how can you think of because possible already has got an axonopathy, pasting of the muscle is there.
So can we do an EMG to confirm?
EMG can be done, but is there any doubt about the axon involvement is wasting on the muscle? Snap is, CMAP is not picked up.
Sir,
The distal to the conduction, so distal to the stimulation, sir.
The distal to the stimulation mean we are stimulating the. I mean, we wrist. There's no potential is picked up. That means proximal also you won't pick up any potential.
Can this be a pronatatory syndrome?
They're very unlikely. Pronatatory syndrome, the other muscles are usually affected. That they're supplied by the anterior nerve muscles.
So this pure motor type of CTS.
Yes, very good. There is entity called pure motor CTS. So the ultimate proof is actually if you want to confirm it, just absent snap in the routine context is not enough. You have to do median ulnar palmar comparison. That is more sensitive. So we did a comparison study. That's again normal. So this is just a few words about this comparison study. There are many. This is how it is being done. We picked up from the nerve is stimulated and picked. This is a combined sensory and motor potential is picked up. Mixed nerve potential it will stimulate even the largest fibers from the muscle spindles. They are the most susceptible to the pathology. Short distance, because of the short distance, it minimizes the length of normal nerve that dilutes the slowing. If you got a long nerve, then the mild slowing can be missed. But a short distance, even the mild slowing can be picked up. That's the advantage of this conduction. So palm-rich conduction median sensory latency difference of 0.4 is significant. Here is only 0.1. So it's a procedure choice when motor latency and symptoms are normal. That's a procedure. That's again normal. Oh. So now question comes: what is causing the thenar muscles, wasting thenar muscle, the absence edema, and normal snap? So thoracic outlet syndrome causing D1 root. But what is over against possibility, as Joy has already said, normal ulnar snap and complaint of numbness of the tip of the thumb. So that is against. In carpal tunnel, thoracic outlet, we expect, if at all sensory is to be affected, we expect the sensory loss to be in the ulnar distribution. But that may not be there all the time. Only pure motor can occur. But you can't explain the numbness of the tip of the thumb. What to do now?
Cervical spine MRI.
Okay, cervical spine MRI. Now, next question. Somebody asked about, can CTS produce pure motor affection? Answer is yes. This is from the literature. This I have seen patients also like that with pure motor CTS. Can the pure thenar muscle wasting and weakness? Yes, because the recurrent motor branch sometimes branches from the median nerve prior to the carpal tunnel, but travels along with the median nerve under a transcarpal ligament. Because of this, the recurrent motor branch will be selectively and more severely involved in comparison with the main median nerve during compression of the carpal tunnel, leading to motor predominant presentation. So that can also occur. So this possibility, but it's unlikely because she has sensory symptom even though NCS is normal.
Sir, can we compare the snaps like we do in that dad's neuropathy, that terminal latency and the difference?
Transneuropathic terminal latency difference. Yeah, yes.
Any hypopigmented patches,
Pardon?
hypopigmented skin patches.
No skin patches or anything. Now, this is all simple cases. But
This
yeah, tell
symptom
me,
could be
Vidya.
a small fiber symptom. It's not picked on nerve conduction.
Yeah, that's good. That's possible. That's possible. But do you think they say the same thing which answer there is such a severe compression of the motor nerve without only pressing the small fiber is very odd.
Sir, this MRI thoracic outlet syndrome ruled out, sir.
No, not done.
It has
I
to be
did.
done, sir.
Sensory picked up from thumb,
Why
sir.
no?
Yeah,
The
that's
thenar
answer.
muscles. Thenar muscles are innervated by C8.
That agreed. But that's not the answer. I did not do that for the reason someone else answered that question just before that. Is it Joy who said that?
No, sir. Me, sir.
Okay, tell me. Yeah. You said it correctly.
Oh, okay. No,
Okay.
it was the sensory done from the thumb, sir. Sensory stimulation.
Exact. That is the answer I want. Okay. So here complaint is in the thumb. Usually NCS is done from the index finger or the middle finger. Usually index finger. We don't usually do it from the thumb. Okay, because it's also supplied with the radial also. But so you compare where complaint was in the thumb. So we should pick up from the thumb. Usually carpal tunnel syndrome, they do not complain of numbness of the thumb. They complain numbness of the middle finger, less commonly index finger, maximum in the middle finger. This lady so happened that she complained of numbness of the thumb. So you have to put an electrode in the thumb. And that's what you got obtained there. You got a gross different sensory potential from the affected side. So always in neurology, what's more important is as always teach common sense and logical thing. Okay, simple thing can solve the issue. So I called the electrophysiology, put the sensory condition again with the electrode in the thumb, that picked up the decreased amplitude. Okay, always try.
Ultrasound of the wrist also can be useful.
Yeah, that can be done. Of course, the subsequent thing is once we confirmed it is a carpal tunnel, then we can do. Anyway, she needs surgery for the same. She's also a patient of rheumatoid arthritis. So much compression that surgery has to be done.
So what is the explanation for the thumb, involvement of the thumb alone?
That is difficult to explain. But see, many person carpal, they do not complain of sensory symptoms. Sensory electrophysiology, we can pick up that. They complain only paresthesia, no sensory loss as such will be there. Here she complained of paresthesia and loss in the thumb only. Anyway, and this is only to tell you that you have to modify test according to what the patient symptomatology. We do not just blindly send for a nerve conduction study like that. Every conduction study has to be decided on the clinical finding. That is why the first statement in all electrophysiology tests is one thing. ADS is an extension of clinical examination. Never electrophysiology should be done alone, interpreted alone.
Sir, one question. Sir, in this patient, if there was no history of trauma and she was a patient of rheumatoid arthritis only, so how would we differentiate median nerve mononeuritis from a picture like this, sir?
Yeah, definitely. Even if the trauma is totally unrelated. See what happened. This trauma is nothing to do with the patient's symptomatology. She detected casually numbness and she attributed to the trauma. That's often the situation, no? Where people will notice only when something else has happened. So this is just like any other carpal tunnel syndrome, only just a carpal tunnel syndrome. Many times the wasting goes unnoticed by the patient.
So is the patient likely to improve from surgery?
Yeah, likely, because if the muscle is totally wasted, she will not.
Yes.
Yeah, anyway, we will give a trial for that. That's all can we do.
Sir, any role for EMG for assessing the prognosis after the surgery?
Yeah, then we can do that. We can do that after surgery. Can do that. Okay, shall I go to the proper case? This is only a short case.
Yes.
Okay, now this is a proper long case. It's a 75-year-old diabetic man presented with history of fatigable weakness in lifting both shoulders for 3 months. Drooping of the head forward on prolonged sitting and standing, 2 months. Occasional drooping of the lower jaw, 2 months. Difficulty in getting up sitting position, 1 month. So history of fatigable weakness in lifting both shoulders, 3 months. Drooping of the head forward on prolonged sitting and standing, 2 months. Occasional drooping of the jaw while eating is a classical symptom of myasthenia, 2 months. Difficulty in getting up in sitting position, 1 month. So this is the video of the patient. Examine. You find that horizontal movements are relatively okay, but vertical movements are restricted. Downward is restricted. Upward is also restricted. That's one finding. I'm only showing the positive findings. Come to the lower facial. Yes, good. We know wasting of the tongue, but fasciculations could be seen in the tongue. Did you see the fasciculation on the side of the tongue? See that one?
Yeah. Yes, sir.
Yeah. But the tongue does not appear to be much wasted. Fasciculations were there. Probably mild wasting on the side of the tongue. Orbicularis oculi were weak. Jaw muscles, opening of the jaw, the lateral pterygoids were weak. They can easily overcome this opening. Neck muscle was weak. There is some fatigability.
66.
We said 66. Then
66, 66, 66, 66.
So at the end, it becomes 60C rather than 66. It's good. You cannot keep his hand elevated, it drops down. Proximal muscles were weak. So also distal muscles. He cannot flex the tongue in the lying down position, may indicate abdominal or neck muscle weakness. Hip flexion was weak. Distal muscle is quite okay. Reflexes normally elicited in the upper limb. Lower limb knee jerks on the slightly brisker side. Ankle jerk normal. Plantar mute or indefinite. Or flexor rather than flexor plantar. So on examination, restriction of all ocular muscles, mainly vertical, maybe horizontal, maybe you can take it as normal. Mild ptosis, no fatigability. Weakness of orbicularis oculi. Weakness of lateral pterygoids, the opening is weak, closure is strong. Fibrillations in the tongue, but no wasting. Tongue movements normal. Motor system, the upper limb, grade 2-3 power of proximal muscles to the upper limb, 3 to 4 in the distal muscles. Lower limb, grade 4 proximal muscles, 5 distally. TTR all 2 plus except ankle jack, which is 1 plus. Probably knee jack is slightly brisker compared to other effects. That we can take it as 3 plus. Plantar flexor. Sensations normal. So, where is the localization probable diagnosis?
So a neuromuscular junction pattern of a element type of weakness predominantly. The
Correct.
only odd point is the vertical supranuclear gaze palsy. I don't know whether it is supranuclear, sir, because you have not shown the other tests. But in old patients, we might get a vertical movement problem if there is some sort of a thalamic stroke or a midbrain CVA or some sort of a microbleed. But otherwise, it is a element type of a neuromuscular junction weakness. And the other odd point is the myokynic movements of the tongue, like a myorrhythmia. So we might get that in some myasthenic syndromes like MUSP, or sometimes also in paraneoplastic.
Correct. Yeah, perfectly right. But here, the ocular movement is unlikely to be normal phenomena. In the upward gaze palsy is well known in older individual. Yeah, but not the downward gaze. He has absolutely no downward movement at all.
Sir, any history of CVA brainstem stroke on this patient?
No history. It's all complaints of 3 months duration.
So in that case, we have to also include the tauopathy spectrum like PSP or Iglon 5, in which we might get vertical supranuclear gaze palsies.
Okay, but the predominant complaint you take is a fatigable weakness of the muscles.
Yes, true, sir, true.
Yeah, so I think we should think more of a myasthenic syndrome than anything else.
Most likely myasthenia, sir.
Myasthenia, that is the thing you have to keep in mind. Okay.
And it is not myasthenia, it is fibrillation only.
That's fibrillation only, not myasthenia. Correct, fibrillation is only. Okay,
And
so what?
Fibrillation we can get in myasthenia.
Yes, you can get. You can get wasting and fasciculation, fibrillation, or cannot get myasthenia. I have shown a case of myasthenia some time back also with the wasting and fasciculation at that time. Okay, so these are the diagnostic possibilities. Acetylcholine receptor antibody myasthenia gravis, anti-musk myasthenia gravis. Or Eaton Lambert can be considered even though represented present. And the old man with myasthenic phenomena, you have to keep that possibility also. So what investigations you need?
Sir, was the VOR and the Bell's phenomena seen in this patient?
That was not done at that time. Because our concern was predominantly what myasthenic syndrome. With all our element weakness, wasting and fasciculation.
Sir, anti-AChR antibodies and RNS.
Yeah, correct. Okay. So in since an RNS was done, this is the median potential. The left median was not elicitable, maybe due to carpal tunnel, we don't know. But right median also amplitude is low. Ulnar is okay, not much of a problem, mild decrease in the amplitude. Then peroneal amplitude, left peroneal is also decreased. And FA's median ulnar both were absent. Peroneal normal, antibial normal. Sensory potentials are all normal except the left superficial peroneal. That may be totally unrelated because he has no sensory symptoms. Median may be part of his carpal tunnel because motor potential is also absent in that area. Whether the sensory we have to take into consideration is doubtful because that does not clinically go with the patient's presentation. So, no potential spectrum from the left ulnar median now. Decrease CMAP amplitude in the right median, right ulnar, peroneal, mild decrease only. No snap from the left median nerve and superficial peroneal. These are the findings in CS.
FAs are absent in ulnar, no?
Pardon?
FAs are absent in ulnar.
FAs, ulnar is normal. I'll show you that. I was in the ulnar, correct.
Sir, what was the carrying angle of the left arm? It was normal.
I don't remember that thing.
So, sir, only one ulnar snap abnormality, but the rest is like a motor axonopathy. We should
Right,
confirm
yes.
with EMG because
You're
this
right,
looks
you're
like
right.
ALS, sir.
Yeah, correct. Yeah, I think you should not take the sensory into consideration at all. Because even if you find some number, it may be, as you correctly said, it may be unrelated, some carrying angular summer pressure policy is likely. Or at least you have to do the conduction again. When properly do the conduction, you may pick up the normal potential. No, that I agreed with that possibility. But do you think that is clinically relevant in our patient? Because she has no sensory
No,
symptom.
Yes, sir. It's not relevant, sir.
not
Relevant.
allowed.
And that's why we did not go after that unrelated finding. We got it, okay, very well enough. So we have to go for the main diagnostic test we have to do. So what test we like to do?
EMG, sir. EMG.
EMG or RNS?
Sir,
RNS.
RNS, but sir, supranuclear gaze palsy with such an axonopathic picture, we should consider motor neuron.
How can it be certain about supranuclear? Ophthalmoplegia or ocular muscles can be affected in myasthenia also.
Sir, but the ocular movement problem in myasthenia is generally choppy saccades, not this type of a vertical supranuclear
Yeah,
gaze palsy.
that part is agreed. That part, but that by that alone, can we say it is entirely thinking different etiology in this patient? Yeah, let's agree with you. Your point is well taken. But what is
But
the main?
it
Pardon?
does not, myasthenia, there is eye movement abnormality, does not obey any rule. It can
Yeah,
happen
sir.
any.
Any muscle can be affected. Yeah. Okay, but the main thing is fatigable weakness, jaw opening, the cellular myasthenia syndrome presentation. So this is the RNS. Shows decrement in the right trapezius, decrement in the right facial. Right ulnar, there not much of a decrement. So I'll show the values. Right trapezius is more than 18 to 18% decrement. 2-minute exercise, 30% decrement. All nerves show decrement. That is, awareness, ulnar, trapezius, facial show decrement response after exercise. And the CMAP did not increase after 10-second exercise in the right median peroneal nerve. That nerves low CMAP amplitude, the low CMAP level than the nerve. So did after exercise, post-exercise, took for any Eaton-Lambert phenomenon, that is increase in the amplitude. So that was not there. So it's got a positive RNS. So what do you like to do?
Mask.
Antibody panel.
Mask antibody, correct, perfectly right. Chest X-ray was done, no thymoma. ECHR antibody was done, that is negative. Mask antibody, patient could not afford a mask antibody because it was costly at that time.
So
So
give a
treat
trial
as
of
if
the
it is
patients.
hydroxychloroquine.
Pardon? Can you tell me once again?
EMG.
Trial of
EMG.
hydroxychloroquine.
Trial of aerodistic is perfectly right. Okay. So
But
new
new
stigma yeah.
sir. I was asking the same, sir. Sorry.
Okay, so okay. So new stigma test was done, it is negative.
EMG, sir.
Okay. So yeah, the question now comes, can be myasthenia gravis? New stigma test is negative. Positive in generalized myasthenia is 80 to 95%. Tongue fasciculations are against classical myasthenia gravis. Now, you can have rarely tongue atrophy in myasthenia gravis, as in this case report. And here also another case report, life-threatening misdiagnosis of bulbar onset myasthenia gravis as motor neuron disease. You were diagnosed motor neuron disease, ultimately found to be bulbar myasthenia. How much can we rely on exaggerated? That's the question they asked. So in this patient, there was delay of 5 months and sustained deep-ended reflexes, presence of bulbar palsy at the start of the disease, and a negative response after cholinesterase inhibitor treatment, such as that's again is also negative in that particular patient. Ultimately, it turned out to be bulbar myasthenia. So now next question is, why not atrial damped? No increase CMAP, that's already told you. Why not anti-musk? Possible. What are the points favoring early facial bulbar involvement and tongue fasciculations can occur? A native neo testament does not exclude anti-musk antibodies, only positive in 60%. So what are the points against age of onset? Usually the mean age is 40 years, range from neonate to 68 years. Sex more than 80% in females. Even the fasciculations are seen, no wasting of the tongue is seen in this patient. Now question now, will you start the patient out for generalized myasthenia or not, or will you wait? What will you do?
Because it's
Yes,
a
sir.
pretty
So we
fast,
should do an EMG first.
Okay, correct.
So
EMG.
won't be a good choice.
Okay, right. So let us say we have no definite confirmatory test for myelin disease, even though RNS is positive.
So one question, sir.
Yeah.
Sir, was there any history of perioral numbness in this patient
No,
or any facial?
no numbers anywhere. Nothing.
Okay, sir. Okay, sir.
Fatigability
So
can happen
because
in MND. Yes, that's important point. Fatigability is well known in MND. You can have a positive RNS in MND also. That I'm coming to that.
so few days
So
back you
ocular
had
involvement is
shown.
rare with MND, sir.
Pardon?
Vertical gaze palsy or ocular weakness is rare with MND.
Yeah, that is very unusual in MND.
It can occur in TDP43 and FUS, the
Yeah,
variants of MND.
there are variants where you can have these things. They can
So a
have
few days back, you had shown one patient of facial onset sensory motor neuronopathy, which was behaving like a myasthenic syndrome, but turned out to be motor neuron-like disease.
like sedation. Yeah, that is also TDP43 like presentation can
Yes,
have
sir.
a ocular muscle involvement also. So that is not against, but it's not common. That's usually seen in familial type of ALS and die. But it's not common to have ocular muscle affected. So when you get fatigability, you think of myasthenic syndrome first. But that's why the case has been brought. No, what
Any
other?
history of a sleep disturbance like
No,
snoring, abnormal behavior? Okay.
no features as Negron 5, nothing.
Yes.
So MRI brain was done. Why do you want MRI brain for?
To rule
Because,
out PSP-like pathology or something.
not only that, rarely in
MND.
this, rarely brain stimulation can present like myasthenic phenomenon. Like it's classically described tactile lesions. This tactile glioma presenting in generalized myasthenia. And there are many case reports where the brain stem lesions, especially tactile region, can present like fatigable weakness. See, this is another case report, brainstem gliomas in adults. Of interest in one patient who presents fluctuating weakness of upper limbs with fatigability and improvement and trust. She also had intermittent nasal voice, swallowing impairment, and a positive neostigmine test, which led to the tentative diagnosis of a myasthenia gravis. Then pseudomyasthenia in patients, another case report of pontine glioma. like B-cell lymphoma, brainstem masquerading as myasthenia, brainstem compression by giant vertebral aneurysm mimicking it. There are so many cases of brainstem lesions can produce myasthenic symptoms. So in the absence of any positive news documented, especially, you have to rule out other conditions before you have to rule out think that it could be.
But
So
in this
MRI
case,
brain,
In
sorry,
certain
Warner.
case of brainstem gliomas, we should also get some sensory abnormality over the tongue and other features.
That need not be there. This is all cases with just like myasthenia due to brainstem, especially in the tactile region. You need not get any this thing. Only ocular muscle will be affected, or body limb muscle may be affected.
Will they present
That's
with generalized myasthenia, sir? They will present
Yeah,
with ocular myasthenia only.
no. They proceed generalized myasthenia also. That I'll show this one. See, fluctuating upper limb weakness. These are rare, but the idea is that before treating as a myasthenia, if you have a definite proof, it's not there. No, SHR antibody is negative, mask you could not do, and the neostyping test is negative. Then we have to put the patient blindly on myasthenic treatment. You have to, can put it if the other possibilities are ruled out. So what I'm trying to say is that in such situation, we have to rule out a brainstem pathology also is to be ruled out. That's the only thing I say.
True,
Before
sir.
anti-myasthenic. Okay, MRI brain was done. That is normal. Now what will you do now?
Sir, whole body PET.
So some frontal atrophy is there,
Doing
some
EMG.
temporal atrophy, frontal atrophy.
No, not much. Not very convincing. It's not there. But the frontal part, in fact, uppermost cut is not there. So I cannot say, rarely say frontal atrophy is there or not.
EMG.
Sir, whole body PET. Na?
EMG, sir. EMG.
So this is the next one as Joy is telling. Positive RNS is well known in MND. I myself have seen 2-3 cases also. In 40% of the ALS, you can have positive RNS. However, ocular muscle involvement is odd, even though it is well described. The fatigability muscles is very convincing on the history and examination. So, this is again case report showing that decubital response of gait more than 5 recorded in 50% to 54% of the ALS patients, and a decubital response greater than 10% in 43 patients in ALS patients. Then again, this article shows that abnormal decubital response is found in 43% of patients of ALS patients in deltoid and trapezius muscle respectively. They are more frequently found in trapezius muscle than those with deltoid muscle. So undoubtedly, decubital response can occur in ALS. So you need EMG. So this is the EMG done. Profuse. The volume is not there. Why? Sorry, what is happened to the volume? Just 1 minute.
Sir, we can't hear your voice if the EMG is playing because, sir.
Wait 1 minute. Just because the sound is not coming here. I might wondering why the sound is not coming. Now it is coming. Oh, when you put it to the other mode, it's not coming. Wait, let me see. Just now it came. Decreased recruitment of motor units, increased firing frequency. This also I'll play. Let me see. There are profuse fasciculations and fibrillations. Why the sound is going in between? I don't know. Anyway, you heard the noise. Typical fibrillation. Now, what do you want to do?
Genetics.
genetic study. So this was a period when genetics was not that common, this case. So is it MND myasthenia overlap syndrome?
Yes, sir, most likely.
Most likely. So ALS myasthenia overlap syndrome, we have 2 case literature. So these are the 25 cases report literature. The patients divided into 4 groups. 12 patients myasthenia followed by ALS. 8 patients ALS followed by myasthenia. 5 ALS with false positive acyclovir receptor antibody. Other 2 ALS patients with only myasthenic syndrome. This is again from India, the case report. Myasthenia gravis with motor neuron disease. Again, this case report. Now, do you think it's an overlap syndrome or anything else?
Sir, genetic ALS.
Yeah, that's the thing we have to keep in mind. Very good. So, or an atypical
So can mass myasthenia show fibrillations on EMG?
Yeah, usually this patient has usually fibrillation seen in the tongue. Here, all the muscles showed innervation. There is a wasting of the small muscles also.
So can mass myasthenia show fibrillations on EMG?
Yeah, in the tongue, yes.
No, not the limb muscles.
Limb muscles, as far as I know, the literature also does not say that. But the one patient I had did that is normal in the limb, only picked up from the tongue.
Can it
Nice.
be only ALS?
They
Can
were
it be only
mentioning
ALS?
fibrillations can be seen on musk also.
In limb muscles also.
They're not saying which muscles, EMG highlighting muscle memory irritability and with fibrillations among notable findings in musk.
Yeah. So, anyway, that patient one, only I had seen 1, 2, 3 patients. That patient I did, it is normal in the periphery, only in the tongue.
Sir, we had a patient of myasthenia who had fibrillations, but it was due to critical illness, motor neuropathy, sir. It was long stay in the ICU, so we had fibrillations, peripheral.
If you find diffuse fibrillations and fasciculations with the wasting of the muscle, generalized myasthenia, think of motor neuron disease rather than anything else, rather considering a
Yes,
muscle.
sir, yes, sir, definitely, sir.
Can be only motor neuron disease, ALS.
Yeah. So we now know that limb muscles are due to antecondylar disease. The only finding the odd for MND is the affection of the ocular muscles. Now, what will you like to do? Genetic test is
Trial of steroids.
Gen-
okay. Now the next question is, if it is in fact, the doctor has already pointed out at that point. If we wanted to be certain whether ocular muscles are LMN or not, is it a muscle involvement or supranuclear involvement? That is the next thing to sort it out.
Ward and Delson.
No.
Okay, so I did one bedside test which almost conclusively excluded myasthenia. What is that test? Ocular cephalic reflex. In fact, he has already mentioned that. Why ocular cephalic differentiate whether the extraocular muscle abnormality supranuclear or infranuclear? As Bindu was telling me, okay, in myasthenia, any muscle can be affected. They can only pure upward movement can be restricted sometimes. So that's not a thing, and to rule out differentiate the two. But if you can demonstrate that that muscle is moving reflexly, then it can be any element parts, including myasthenia. So let us see the ocular cephalic reflex, vertical ocular cephalic reflex.
Supranuclear.
It's supranuclear, as correctly said. So what is the diagnosis now? What is the supranuclear gaze palsy with motor neuron disease?
TDP 43, sir.
Yeah, correct. Can be something like that. Let us see. Paraneal CT chest was done because we had to roll a paraneoplastic. This antibody profile was normal. Now these are case reports. Before this NT test become so common. There is atypical motor neuron disease, supranuclear vertical gaze patterns, slow saccades. Then another one, this thing, marked neuron losses present RAMLF in both the patients. FTP, TDP with motor neuron disease. So these are all case reports where you can have supranuclear palsy, gaze palsy with motor neuron disease. Some of them with the FUS and some of them with ADP43. Some without any of these things can also be described. But they are rare. The point I brought the patient is such a situation, one should, naturally we will not do the oculocephalic because we know muscles are affected. Then naturally we think that is also LM and we never think that is UM. We get in the presence of an LM finding. See, in the case of ocular muscle affection, if the affection is symmetrical always to oculocephalic reflex to gaze palsy, when one cannot look for a wasting and fasciculation, that's a problem. See, in the ocular muscles, you can look for a wasting and fasciculation. All of other muscles, you can do EMG and find out the fasciculations and all. But as far as ocular muscles, we cannot do. The only way to prove or disprove differentiate UM versus LMN is looking for this kind of reflex movement. So that's the story of the patient.
Excellent case, sir.
So yeah, so because it is totally we were misled initially as thinking myasthenia, but the wasting and inflammation, then we started thinking ultimately again last moment we were wondering why the ocular muscles are affected. We cannot explain. Then only some more of it stuck my mind to the oculocephalic. Then we found the answer. Okay. Any questions?
Bye.
Okay. Shall I go to the next case?
One doubt.
Yes, sir.
What treatment was given, sir?
I think we did not give any specific treatment for this patient. What could we do in a motor neuron disease? We tried a pyridostic mineral, we tried, but without any improvement at all. Okay, shall I go to the next case?
Yes, sir, please.
Okay. This case is from Dr. Samia. This is a 26-year-old male. Progressive weakness of both upper and lower limbs for the last 8 years. And thinning of all muscles of the body. So progressive weakness of upper and lower limb and thinning of the muscles. And
আঙুলটার দিকে তাকা হ্যালো এদিকে তাকা
movements are all restricted.
এদিকে তাকা উপরে তাকা
Movement down movement all
নিচে তাকা এইবার তাকা উপরে তাকা নিচে তাকা তাকা উপরে তাকা নিচে তাকা এবার নাকের দিকে তাকা আঙুলটার দিকে তাকা জুড়ে আঙুল টাকা তো বাবা
more on the right side.
জিভটা বার কর হ্যাঁ
Tongue was wasted with fasciculation.
জিভটা ভেতরে রাখ ভেতর বাবা হালকা করে বার কর জিভটা বার কর
Generalized body wasting, you can see the fasciculation in the body and the trunk muscles also. Erectile is made.
একটু নাম তো বাবা
Scapular muscles are also.
কাছে নিয়ে এটা দুটো হাত সাইডে কর দুটো হাত সাইডে কর ঠিক আছে
The wasting of the small muscles in the head.
আঙুলগুলো সোজা করা সোজা কর
And all muscles were weak.
চেপে ধর আঙুলটাকে ঠিক আছে চেপে ধর
Reflexes were elicitable, even though with severe wasting is there, well elicitable reflexes. In finger pressure is also seen.
এটাও ডিসকাস
Slightly brisk and great reflex. Both knee and hemichex were brisk.
মাসাজ
And there was
এদিকে একটু এক্সটেনশন
So thin-built, emaciated individual, craneless, all ocular movements were absent. Sorry. Bilateral facial weakness, tongue wasted with weak with fasciculations. Motor all upper limb muscles were wasted and weak, including scapular muscles. Lower limb muscles were also wasted and weak, but less compared to the upper limb. Detailed upper limb reflexes normal. On testing the finger flexion, finger flexors do contract mildly. Lower limb DTR were brisk. Sensations normal. Plantar outgoing. So what is the diagnosis?
No myotonia, sir.
No myotonia. Young individual, 23-year-old.
Some form of myopathy, sir.
Congenital myopathy, sir.
It's got severe wasting and fasciculations of the muscle, tongue fasciculation. No sensory.
Pure motor element syndrome, anti-Hansel itself is
Yeah.
possible, sir.
Yeah,
He
I
has
think
complete
about
ophthalmoplegia. So possibility, young individual, any family history should be asked for, sir. Mitochondrial cause should be ruled out, sir.
Yeah, it's a good thought. Multiple myopathy can present like that. Even some lipid-sore diseases like EM2 can present with predominantly element findings.
So no family history.
Hearing normal, sir.
Okay. Hearing normal, hearing. That is a good thing. Good question. There's a treatable
normal,
condition.
sir, normal.
Fluid transport deficiency can present with element finding, with eye findings.
Hyperthyroidism.
Hyperthyroidism can be present like that with such a total ophthalmoplegia.
Which transport deficiency, sir?
Pardon?
Which transport deficiency?
Riboflavin transport deficiency.
Riboflavin.
That is our BBVL or the BVVL. Brown
Violator von
Lorentz syndrome.
The Madras 70.
It's actually not Madras 70. There is something mimicking that.
Yes.
Madras 70 is a static condition. This is gradually progressive with sensory deafness.
BVVL and the Fazio-Londe syndrome are the two riboflavin.
Yeah, right.
Yeah.
The original facial onde have been now replaced. Nobody calls now facial onde. Most of them are actually these conditions only.
Do they become normal with riboflavin?
Yeah, they become normal. That's the thing. They improve remarkably. Even the wasting also disappears. Ocular movement, everything disappears.
No.
You have to give high dose riboflavin, but it's a very cheap drug. So never forget to do this particular test if the patient has associated deafness. So ALS with ophthalmoplegia. So any other test you would like to do in this patient?
Oculocephalic reflex, it seems.
Exactly. You are right. Just like the previous patient.
আচ্ছা এবার ক্যামেরার দিকে তাকিয়ে থাক
The oculocephalic, see the eye also moving normally. This is also.
তাকা ক্যামেরার দিকে তাকা
So what is the diagnosis?
Supranuclear, sir.
So it's a supranuclear. Just like
আচ্ছা
like our previous patient, supranuclear gaze palsy with ALS. This is more clearly ALS. There it was fatigability and things like that. It's not here. There's not much of a confusion. So what are the investigations we like to do? MRI brain was done. That is normal.
Genetic tests.
Yes. That's better thing will genetic test, which will become many other things. Then we can for the other things. So EMG was done. EMG showed neurogenic pattern. This is sent by Dr. Sami. I cannot, with the video is not available. Anyway, it shows undoubted neurogenic pattern with the decrease in difference and fasciculations and fibrillations. And severe decrease in the recruitment. And RNS was negative. FDG PET was done. That whole body PET did not show any evidence of metabolically active disease in the present study. Now, what else?
Whole genome sequence.
Okay. This is as the previous, or as Dr. stated in the previous case, this is the first positive ALS. Then what is this first positive, TDP positive, I'll tell later on. So this is one of the genetic ALS with supranuclear ophthalmoplegia due to this first protein abnormality. So this is the article on genetic. A few words about this. First can present in two ways. Can present ALS, otherwise with dementia, FTD. Two types of presentation can occur with first protein. So first ALS as in our patient is an autosomal dominant mutation in the gene encoding DNA and RNA binding protein, FUS, are cause of ALS, and about 0.3 to 9% patients with ALS are first mutation carriers. First mutation associated ALS is characterized by early onset rapid progression compared with other forms of ALS. However, different pathogenic mutations first can result in markedly different age of onset symptom, age of onset, and the rate of progression depending upon the variability in the mutation. Then the other presentation of first protein is the FTD. That is, first protein is fused in sarcoma. There is a full expansion of the first. It's a cause of frontotemporal dementia, especially in rare cases of type of FTD FUS. This neurodegenerative disease is characterized with abnormal accumulation of first protein in the cytoplasm of neurons, leading to breakdown of brain cells and onset of dementia. The features of FTDF onset typically seen in younger individuals, but case reports have shown a range of ages of age of onset. The person behavioral changes is often associated with behaviors like personality changes, impaired executive function, can present language impairment, may spend language problems such as aphasia, semantic language dissociation, and motor features, and it's like motor neuron disease. So that is the story of this. So two similar cases, one in an older individual, which is not less likely to be genetic ALS because the age of onset and all. The second one, typically genetic ALS.
Any family history for this patient?
No family history. This
So there
patient
was no family history and no hearing abnormality and no ocular vision abnormality in this patient.
correct. So shall we go to the next case or stop here?
So next case.
One more case. Yes. No, and I couldn't hear you.
Samia, why did you specifically say vision abnormality?
So because in certain cases of BVVL, we might
Why did Samia
also
say
get,
no visual abnormality?
yeah. Excuse me, Dr. Samia. Yeah.
Yeah.
I said vision abnormality because in certain cases of BVVL, you get both optic atrophy and vestibular and auditory abnormalities. So you have to look for both the VEP, beta, and all these things when you are suspecting a riboflavinopathy.
You mean riboflavin transporter deficiency, yeah?
Yeah, correct.
Yeah, we even tried a high dose of brentamine for this patient, but she showed no improvement at all.
Okay, any more questions? You can ask Sami about this case. He knows better. It is his case.
No, sir, not at all, sir.
You only sent the case to me. Thank you.
Sir, we were also very puzzled about this case. Had the genetics not come, we were planning to start him on some kind of pyridostigmine because, sir, in one MRI cut, you can see the orbit. The muscles are absolutely atretic, just like a CPEO. But there was actually no CPEO. It was more of a chronic progressive internal type of an ophthalmoplegia, which we can describe in ALS because in CPEO we would get negative oculocephalic reflex. But in this case, although there is atrophic muscles, we are getting normal OCR, which only occurs in the genetic ALS like FUS and TDP43.
Correct. So the fact that OCR is octacephaly is preserved tells you it is UMN. There can be associated LMN also. Just like ALS, for this patient also has got LMN UMN finding in the limbs also. Same thing can also occur in ocular muscles also. In fact, that is the point which tells you it is ALS when you have got both UMN and LMN finding.
So the muscle abnormality is shown in the MRI. You can see the orbital cuts. There is absolute atrophy of the inferior rectus, lateral rectus, everything.
Right. I think I'll show one more short case.
Yes, sir.
Okay, this is a story of a 57-year-old female. History of tremulousness of the limbs and body for 2 years. History of excessive tiredness. One episode of GTC seizure 1 year back. Not on any anti-seizure medication. No further recurrence of seizure. Now, this is the history only, short history, 2 years tremulousness, history of excessive tiredness, one episode of GTC seizure, and family history seizure also. There is father had again one episode of seizure. Looking at the patient's examination, everything was normal. Motor power was normal, but on asking, keep his hands to his eyes were tremulous. He got tremor-like movements of the hands. Look at the hand very carefully, the movements. Okay.
Same, sir.
Pardon?
Same, sir.
Same.
Yes,
Yes.
Sir, on any is she on any anti-epileptic, sir?
She's not on anti-epileptic. She's never
Yes, sir.
been
Then this is fame, sir.
Yeah. This actually this case I showed some payments. See, I'm seeing so many cases of such patients now recently. I have another patient also at the moment. So these are all, everything is normal except for this mini polymyoclonus like phenomenon. They are not actually a tremor. Some people call it cortical tremor, actually should be cortical myoclonus. It's not rhythmic at all. Irregular type of pain. All other sensory examination, everything normal.
That myoclonic epilepsy. What is this? AME.
I'll come to that, because I showed a series of cases 3-4 weeks back. This kind of the point is that they look like tremor. They have been treated by people all as tremor only, but they're actually myoclonus. These tremor responds very well to sodium valproate and clonazepam. Now, these are all I think. Let's give the patient post-surgery. Okay. This is the EEG. The patient shows bilaterally synchronous spike discharges. Even though she had only one seizure, no further episode with the treatment, EEG was abnormal. So she has got polymyoclonus or cortical myoclonus, plus she has got a seizure, and it's a benign condition. It's called familial adult myoclonic epilepsy, otherwise called FAME. This is an autosomal dominant condition characterized by cortical tremor and myoclonus, usually manifesting with second decade of life, infrequent seizures developing on the third and fourth decade. Cortical tremor, they call it cortical tremor. I think last time also discussed, it does not look like a tremor at all. It's the core feature of FAME, which is being considered as a part of spectrum of cortical myoclonus. See the genetic abnormalities, I will skip. So cortical tremor is a rhythmic involuntary shaking, often in the hands, that is caused by abnormal electrical activity of the sensory motor cortex. It is considered as a rhythmic variant within the broader spectrum of cortical myoclonus. If you get a cortical myoclonus with a rhythmicity, you call it as tremor. I think that kind of a argument is not purely justified. If it is a rhythmic, it is called myoclonus. If it is rhythmic called tremor, that's the best thing, rather than calling rhythmic variant effect myoclonus. That is not correct. But both are coming from the excitability, hyperexcitability from the cortex. So this is a cortical myoclonus, the sensory motor cortex. EMG was like that of a myoclonic active, EMG, the myoclonic EMG. Shows synchronous activity in the antagonist muscles and localized EEG spike preceding the jerk as the hallmarks of a myoclonus. Now, these are the difference between the cortical tremor versus cortical myoclonus. Cortical tremor is a rhythmic version of cortical myoclonus and is part of the same clinical spectrum. Both originate from the abnormal hyperexcitable activity in the sensory motor cortex. Distinguishing features, while tremor is rhythmic and jerky, myoclonus is more generalized term for involuntary twitching. This is the Joy. This is the condition: familial cortical myoclonic tremor epilepsy syndrome, characterized by cortical tremor, myoclonus, and sometimes epilepsy. One of the most prominent examples is familial cortical myoclonic tremor epilepsy, genetic condition carried with triad of symptoms. They present cortical tremor, distal myoclonic jerks, and epileptic seizures. From the literature, it's shown last time.
Does she have a family history?
This patient had a family history of epilepsy. The 2-3 cases which I presented last time, all the other family members also got a similar myoclonic jerky moment. It's not a large number; it's a fine myoclonic jerk. If you look at the hand posturing, if you are totally confused with that of a tremor, very close examination will tell you that they are not tremor but myoclonus. It's irregular. See the jerky movement in between coming. See that movement. So that's not a tremor at all. That's myoclonus only. The jerky movement. See, it's not uncommon. The point I'm bringing is not uncommon. Seeing more and more cases you'll be seeing in your practice. With this kind of, kindly look for this myoclonic movement or that tremor. Many of them, those so-called tremor who do not respond to your classical tremodone and things like that, consider this possibility.
Sir, do we need to do neuroimaging if there is no improvement with valproate?
The other, not this patient, the previous patients had undergone neuroimaging. Nothing was there in that neuroimaging.
So because sometimes we had a similar case where we had diagnosed this condition, but later when we did the neuroimaging after no improvement, it came out to be FX test like of a presentation, that fragile X tremor ataxia syndrome.
Yeah, right. That's correct. But the difference is that here it is very benign. No other symptom for the no ataxia, nothing except for the tremor. And my epilepsy also.
But in our patient also, sir, there was no other symptom, just that.
Okay. So maybe some variant of a fragile X tremor syndrome. Now there's this fragile X syndrome as well as NAD, neural inclusion body disease, can have various type of presentation. Sometimes they can present without any findings, only stroke-like presentation.
Yes, sir. Yes.
This I want shown one sometime backward. And they can have also tremor, sometimes only seizure. So the spectrum is quite varied. And both NAD as well as Fragile X have got this spontaneous hypertension.
MCP sign, yes.
MCP sign. Only genetic test can differentiate between the two. And again, there will be genetic overlap also, both these conditions.
Yes, sir. Both can occur in the FMR1 gene abnormality.
Yeah, right. So the presentation can be varied. But this patient did not have any MRI abnormality at all.
So what did you give?
Are you medical college teacher?
Pardon?
Sami, is he a medical college teacher?
Sir, I did not understand what he was asking, sir.
Yeah. Joy Kettle, I did not hear you.
Sami, are you a medical college teacher?
No, sir.
Sami a medical college teacher?
No, sir. I am a third-year resident at Bangalore Institute of Neuroscience, Kolkata, sir.
Fantastic.
In fact, I have been seeing this case for many years. I was not, all these things I have been treating as progressive myoclonic epilepsy benign variety because for want of a term. So this is the term which has come up now in the literature. But this I have been seeing for many years. A benign variety of intentional myoclonus along with responding to sodium. These patients do respond very well to sodium valproate and also clonazepam, if necessary. They do not respond to propranolol or this thing.
It's like an adult variant of JME, juvenile myoclonic epilepsy.
All right. Different called, this is continuously present in postural myoclonus, continuously present, mild type, not that away, JME type of myoclonus.
But the response to valproate is similar.
Yeah,
That's
right. Yeah, any myoclonus response. Okay, shall we stop here?
This NAD and the Fragile X, they present with ataxia, no? Will they present with myoclonus like this?
Yeah, that's called tremor ataxia syndrome. So that's classically, tremor ataxia syndrome, but they can mimic a myoclonus. They can also associate myoclonus also can occur. The NAD, there are various presentation, cognitive presentation, myoclonic seizure presentation, epileptic presentation, stroke-like presentation, all have been described. I don't know whether you remember I had presented one case before.
Yes, sir. Yes, sir.
Which one? Neuronal induced sir?
So the difference between the FX TAS and the NINDs is that the MCP sign is much more characteristic of the FX TAS, whereas in neuronal inclusion body disease, we get that hyperintensity in the gray-white junction abutting the U fibers. So that is more specific of the NINDs with the MCP sign.
No, Samya, both these conditions, because regarding the case literature, both can produce what is called as the persistent diffusion restriction. Persistent diffusion, the corticomedullary rejection. So described both in Fragile X chromosome disease as well as in NIAD. That can occur in both. Nowadays, they say that both are allelic conditions only. They're almost similar conditions only. The precedence can overlap between all the two together. The one patient which I had present AD with classical with the cortical persistent diffuse restriction, ultimately turned out to be Fragile X chromosome.
Yes, sir. And we can only differentiate it by the CNS biopsy, sir, because the inclusion bodies will be present.
That biopsy can be done from the skin also,
yes,
the NIAD. But I did that from the skin in that patient that was negative. And then when the genetic test, I showed a Fragile X chromosome.
Yes.
Okay, then shall we close?
Thank you, sir.
Okay.
Thank you very much, sir.
Thank you, sir. Good night.
Thank you, sir. Good night, sir.
Thank you, sir.
Thank you, sir.
Good night. See you next week.